All right, let's welcome to this edition of EMS Journal Club, April 3rd, 2024, with Dr. Eric Doan, one of the EMS fellows. Our next EMS Journal Club is going to be on May 1st. Same link, same time. Uh, Dr. Doan, go ahead, take it away.
All right, sounds good. All right, everybody. So for today's journal club or this month's journal club, I wanted to go over very similar, same theme as what we discussed last time. And back in January, we talked about the post-cardiac arrest resuscitation guidelines that were published in January. And today, I wanted to go in and look at some predictive risk factors in traumatic cardiac arrest. So this article, essentially the question that they were asking was what factors are associated with sustained return of spontaneous circulation in traumatic arrests. And they looked at different predictive risk factors. Some of the objectives today, we're going to be reviewing a recent retrospective observational study that was done in France. It was done using their national registry of, that's their national database. We're going to view some current guidelines from the ACS, European Resuscitation Council, and also from NAUSP regarding traumatic arrest. We'll review the reversible causes of traumatic arrest, and we'll also kind of touch upon, when, is termination appropriate and when is it appropriate to do so. So this study that I sent out, this is a large observational retrospective study. It was published in 2022. It was over a 9-year period from July 2011 to November 2020. It was a French study where they looked and did a retrospective review of a centralized national database. All their records are in a centralized location, so they're able to have good access to it. To the entire country. So a population of 67 million, they were able to get a pretty good, decent number of traumatic cardiac arrests. They use a 2-tier system, actually, similar to New Jersey, where they have ALS and BLS, but it is different. Their ALS, they don't really have paramedics. They have an MD and an RN with a driver. That's their ALS equivalent. BLS is run by their fire service. So as we kind of move forward and as we kind of apply these things as we get to the end, we'll just something to keep in mind that it's a 2-tier system, but the levels of expertise are slightly different. And also a lot of the BLS agencies, the fire brigades, are also volunteer based. Calls are taken at a dispatch center with EMS physicians immediately available, and they determine what resources go to which calls. Their model and in the kind of the European model, we can touch upon later, is to bring the hospital to the patient rather than bring the patient to the hospital. They defined traumatic arrest as a cardiac arrest directly caused by blunt, penetrating, or burn injury. Their exclusion criteria, of course, cardiac arrest that was not traumatic. There had obvious signs of death, injuries incompatible with life, obvious rigor mortis, any children, so age less than 18, and those who are end of life have had documented DNR paperwork. Going through our PICO questions that we use, so their intervention and the comparison that they used. Again, this was a retrospective study to try to identify some predictive factors that were associated with increased rates of return of spontaneous circulation in traumatic arrests. They defined sustained ROSC as being defined as greater than 1 minute. They looked at individual characteristics like patient's age, comorbidities, what exactly type of trauma, was it witnessed, unwitnessed, and they used those different variables to see if they were clinically significant. The patients with sustained ROSC were then reevaluated using the same registry at the 30-day mark for neurological outcomes, and they were graded based on CPC criteria. They also examined the frequency of organ donation for those who didn't obtain ROSC. This is directly from the study, but they initially pooled roughly 120,000 patients for cardiac arrest patients. After the exclusions, they got roughly 4,900 patients in their study. Out of the 4,900, they had roughly 21% of patients had sustained ROSC by their definition of ROSC that was greater than 1 minute. Um, the Out of that bunch, that was about 1.4% had favorable neurological outcomes. And of that percentage, it's about roughly 67 people or so. 70 so percent had good neurological outcomes. They had like almost, there's no significant cognitive deficit. The majority of cardiac arrests were young males. It's about 3,700 of them were male. Amongst patients without ROSC, they reported a 1.4% organ donation rate. Median age was of the younger side, which is pretty common for traumatic arrests, 46. Blunt trauma made up the majority of this, about 80%, and most of the traumatic arrests came from motor vehicle collisions. The median time from ALS to be dispatched and arrive on scene was roughly 17 minutes. Bystander CPR, BLS interventions by fire were also included. Some did, some didn't. I'll get to in a second. Their most common initial rhythm on arrival. This is around 84% of initial rhythms were asystole, so almost 4,000. PEA was the second most common. Their median transport time. This is something we're going to talk about a lot more. But their median transport time is significantly delayed. From ALS arrival on scene to actually getting to the hospital is 85 minutes. So something to keep in mind. This is sort of the way their model is and the way their system is set up. Most patients were intubated by the ALS group, by the MD. It's like 94%. In terms of like really advanced procedures such as REBOA, resuscitative thoracotomy, none were reported in this data set. Then they divided the patients between ROSC and non-ROSC. So they had around, like I said, 20% of patients had sustained ROSC by their definition. Most of them were blunt from blunt trauma. Some of the predictive factors that they found that was more common in the patients that had sustained ROSC was not too surprising. So I mean, they had patients who had some sort of agonal respiration, some sort of spontaneous activity. They had reactive pupils. They were more likely to have return of spontaneous circulation. They were also more than likely to have PEA on arrival or some sort of VFib or VTAC, some sort of initial rhythm rather than asystole. The patients who received IV fluids and packed red blood cells were more than likely to have ROSC, which is not too surprising. We'll get to. They also did not comment on specifically how much was given of each, of which, and there's a few other interventions. Interestingly enough, and this is something I put in bold, is their rates of finger and needle thoracostomy rates were more associated with not obtaining ROSC, which we'll get to in a second. More patients with ROSC were more likely to have IV access, and they're more likely to be. One thing to keep in mind, and this is something that the author mentions, that most patients in this study were declared dead on scene. They did include those who were transported to sort of prevent bias. Looking at sort of their secondary outcome, they were looking at survival and neurological outcomes at 30 days. They had a total of 67 patients from 4,900. 70%, like I mentioned before, had like really good neurological outcomes with CPC scores from around 1 to 2. And there was around a 1.4% organ donation rate. All these things highlighted are the things that were statistically significant in the study. Going by age was statistically significant. The location, people with, let's say, who were in a public place were more than likely that if there's witness, there's more than likely to have return of spontaneous circulation. The majority of them, like I said, are RTA or road traffic accidents, um, while there was a much smaller percentage of penetrating trauma, which we'll talk about in a second. Um, Very interestingly, I'll just note this real here. External hemorrhage control, which controlling bleeding and preventing hemorrhagic shock and subsequent cardiac arrest, arguably, is a BLS skill. Putting a tourniquet on, applying a direct pressure, using a pelvic binder. These are BLS skills. And interestingly enough, one of the things that they noted in this study is that the BLS or the fire departments were their interventions for hemorrhage control were not statistically significant to change outcomes. The ALS or the MD, but the physician's interventions were. They comment on this by saying that a lot of the BLS are volunteer. Maybe they're not as well trained, and that might very well be the case. And as I kind of mentioned before, agonal respirations, having some sort of pupillary light activity, and some sort of organized rhythm, whether it's PEA, VFib, VTAC, more than likely you're going to have better outcomes. Let's go through our checklist of quality. Did the study address a clearly focused issue? I would say definitely. They were definitely. This was a retrospective study. They were looking for some predictive risk factors that they can then move to an additional study. It was a retrospective observational, definitely an appropriate method. They used a national database, so they tried to eliminate bias, try to get a large data pool. The couple things that maybe some limitations of this was have all the authors identified all the important confounding factors. I would argue that there was quite a bit. Two of the things that they were measuring was, sustained rates of ROSC after 1 minute, which is good. I would argue that their definition should also include those who made it to the hospital, because there were plenty, even the author describes this, that there were plenty en route that ended up being pronounced like en route to the hospital. Also, like, what was their neurological outcome at the time of discharge? That would be something that I would want to know. While the 30-day marker is a good marker in terms of studies that we review, it'd be way more interesting to see like what is their neurological status at discharge. Again, these results, this isn't a randomized control trial by any means. This is just a retrospective review. So again, these are generalized associations that we can make. Do the results of the study fit with the available evidence? I would argue no. There's quite a bit that really stands out that's really abnormal that the author sort of talks about. We talked about needle decompression being in this study was way more common to be in the patients who did not receive return of spontaneous circulation. The author talks about this pretty extensively. They say, there was no way to control exactly whether patients received a finger thoracostomy or needle decompression, or was it actually done appropriately. The author sort of argues that, objectively speaking, there are less rates of penetrating cardiac arrest when it comes to European countries as opposed to North America and Canada. The author comments that there's more higher rates of gunshot wound victims that lead to traumatic arrest, and maybe that's why this could be a possibility where maybe they're not as competent, maybe they're not as well trained to be doing bilateral finger thoracostomies, which is recommended by the European Resuscitation Council. We have no way of knowing, so there's a lot of discrepancies here and a lot of limitations with this study. A lot of the interventions, not too surprising. I mean, it's patients with traumatic cardiac arrest, like any cardiac arrest. We're trying to reverse the reversible causes, right? That's what we're focusing on. Medical versus trauma, they're two different things. very similar H's and T's, but again, you're going to be focusing on different interventions. Someone who's in hypovolemic shock and then went into cardiac arrest, give them blood. That's going to be the most beneficial. That then the problem really then becomes, logistics, actually getting that logistically to become a reality. In terms of like tension pneumothorax and cardiac tamponade, that's another easily reversible cause of traumatic cardiac arrest that is very specific for, traumatic arrest. We talked about, yeah, so very interestingly, and this is also maybe not too surprising, epinephrine that was given during the cardiac arrest was not found to be statistically significant for increased rates of ROSC, which makes sense. Again, when you look at the causes, maybe the four most common causes that are correctable and reversible in traumatic arrest, either in hemorrhagic shock, your hypoxia from decreased GCS, and you asphyxiate and you need airway management, tension pneumo, which is an obstructive shock, it needs to be relieved, cardiac tamponade, very similar. Epinephrine is not going to necessarily do anything. You're making the heart pump faster on an empty tank. Most of the blood injuries, like I kind of mentioned, were MVAs or blunt trauma from NVAs. So more than likely they had polyblunt trauma. One interesting thing that was noted in this study is that the patients with blunt trauma had higher rates of mortality as opposed to had less rates of mortality as opposed to the penetrating trauma. So we'll review the body of literature. It's, more often than not, patients with penetrating trauma are much more likely to have ROSC. And really think of it this way: if they have a penetrating thoracic injury, again, with the reversible causes we talked about, there's something that can be fixed. As opposed to things with blunt injuries, polyblunt injuries, multiple things are injured, your patients are more likely to be in hemorrhagic shock. So another big piece was while the study looked at a different country with MDs in the field. There were no thoracotomies, no REBOA. I would argue like no pyocardiocentesis was done. That might be secondary to the prolonged response time. The author doesn't really comment on why these things weren't done. I'd argue probably the prolonged response time. But it's something to think about, that can we adopt some of these interventions, look at this study and can it apply to our side, from our ALS system? Something to think about. We talked about the author's discrepancy of the European MDs having less exposure to penetrating arrest. My biggest thing was, as we kind of mentioned before, there was no follow-up for in-hospital factors. Which patients were, did they die en route as soon as they got to the hospital? Who died an hour after being in the ED? Who was pronounced a week after being in the ICU and didn't make it to discharge? The author really doesn't specify. Bleeding control, as we kind of mentioned before, and the way they sort of describe it, is that the BLS was mostly volunteer and they were maybe not as well trained. I think that's something that maybe is more relevant to their system. I think we definitely emphasize bleeding control and trauma, especially with the March algorithm came out in more recent years. One big caveat with this, another limitation with this, is while a lot of these were from MBAs, the author also mentions that some of these may have been from medical causes. Could have been that, someone had a STEMI while they were driving and then crashed their car. There really is no way to 100% prove that by doing a retrospective study. So maybe that's why the blunt cardiac arrest had some slightly increased rates of survival as opposed to the penetrating trauma, which was kind of unexpected. And they also, didn't really describe like how much IV fluids, how many units of like blood products did they give, which is especially important. If you look at the literature, um, giving excess crystalloid solutions like IV fluids leads to worse outcomes. Can these results be applied to New Jersey? It's a two-tier system, so it's actually very similar. Um, it's similar in some regards, but it's also very different based on like how the resources are dispatched, how the whole system runs. That all being said, I would argue that that while needle decompression is at the paramedic level, out of all the interventions, finger thoracostomy was really the only thing that's not currently in the ALS protocols. Um, Arguably, like you know, if we look, we'll talk about it in a minute, but I don't think that's too far of a skill for paramedics. I don't think so. Hemorrhage control by BLS, I think is something we definitely do well, um, just in general. Um, of course, the debate about blood products in the fields, that's something we'll talk about in a moment, but that's always something that, gets brought up, and it's something that we need to see more further data on. But, let's look at traumatic cardiac arrest throughout more recent guidelines. Let's take a look through our protocols. When I'm looking through the protocols, I kind of looked for like just traumatic arrest. It's mentioned twice in the current New Jersey State EMS protocols. As you can see on line 1, 2, 3, 5, 6, for traumatic arrest, all interventions beyond CPR and spinal motion restriction should be performed en route to receiving facility, minimize scene time, which uh, that's all that's mentioned specifically for the management and um, care of those with traumatic arrest. Um, the second thing was actually the pediatric version. So let's look at the American College of Surgeons, kind of some of their recommendations. This is straight from their most recent, the 10th edition of ATLS, is 2018. So they address traumatic arrest. Their 10th edition of ATLS sort of addresses this as going through the following algorithm. You have about a half a page of dedicated specific descriptions of starting with chest compressions, definitive airway management, so very similar to where you would start any cardiac arrest. Look and address tension pneumothorax through bilateral decompression. Start IV fluid resuscitation. Again, they don't say exactly how much fluids to give. Administer 1 milligram epinephrine, and if ventricular fibrillation is present, treat it according to ACLS protocols. Um, I would say that's something we can talk about towards the end, but it's interesting that this is something that's in in one of their textbooks of ATLS in their guidelines. Then the next thing would be at the physician level be left thoracotomy, whether clamshell or left lateral, and bleeding control should be something that should be immediately done before all of this, so with chest compression and after airway management. But bleeding control for either external, but once you go into the chest, it's looking for source of internal hemorrhage control. This is their algorithm that they have published with ATLS at the most recent version that I could find. This pretty much just describes everything that I just talked about. And again, something to keep in mind is that they recommend chest compressions immediately with IV fluids, and also epinephrine is right in their protocols. And after 30 minutes, recommending if nothing after all of these interventions all these reversible causes are addressed, then termination or pronouncement. More recently, looking at maybe the other side of the pond, the European Resuscitation Council guidelines in 2021. They published a update to their guidelines in 2021, looked at cardiac arrest in special circumstances. This was not very specific for traumatic arrest. They looked at many different scenarios that lead to arrest. But some of the things that, this is definitely way more extensive than, I could find from ACS. They based their data and guidelines on, pretty systemic review and meta-analysis of all the available data at the time. Interestingly enough, if you look at their guidelines, their immediate, this is from directly, immediate resuscitative efforts in traumatic cardiac arrest should focus on simultaneous treatment of reversible causes, which takes priority over chest compressions. Something to discuss, I think. You know, while chest compressions is something that we emphasize in medical cardiac arrest, for someone who has in a traumatic arrest, is chest compressions necessarily working as opposed to starting them on blood products? If you're pumping the chest and they have a source of uncontrolled hemorrhage, they pretty much say like, don't pump an empty heart. Recommendation, of course, and we already sort of mentioned, is hemorrhage control externally from tourniquets, binders, external pressure, with an emphasis on restoration of circulating blood volume through blood products. Very interestingly, they also comment that the benefit of blood products, the pre-hospital transfusion of FFP and packed red cells had significant survival benefit if the transport time was greater than 20 minutes. Something that I think that we need some further studies with, for much shorter times, much shorter transport times. 48% of those in traumatic arrest from all the data they reviewed was from uncontrolled hemorrhage. Again, emphasizing that that's the most common cause. The second most common was tension in the thorax, about 13% of their data they reviewed. Loss of airway, or decreased GCS or something like that was about 13%, and tamponade was about 10%. I'll skip over the specifics with thoracotomy, but specifically for pre-hospital care, and this is common across the board. If there's no specific, if they find someone in cardiac arrest, their recommendation is, if you're not sure whether it's traumatic or not, for someone that was driving and crashed and is in a low speed MVA and they're in cardiac arrest, well, does it look like that the traumatic injury caused does the mechanism make sense? If it doesn't make sense or there's question, treat it as a medical cardiac arrest. Of course, shorter on-scene times are associated with increased survival. This is something we've known for years. Limited IV fluids and crystalloids, blood products are much more superior, especially for preventing trauma-induced coagulopathy. Interestingly, so when we review the CRASH-2 trial, which was the original study looking at TXA, and then the subsequent TXA trials, which maybe we can talk about later. Really, it was the first study that looked at TXA as a benefit for patients with trauma. They put it in their guidelines for patients in traumatic arrest, 1 gram over 10 minutes, followed by a 1 gram infusion. And it should be given within the first 4 hours of the traumatic event. They also recommend, the use of ultrasound and point of care ultrasound in the field. That can be easily used to determine a lot of the reversible causes of traumatic arrest. This is their algorithm that they use. That's in their guidelines, kind of very similar to what we just talked about. External hemorrhage control, securing the airway and preventing hypoxia, decompressing the chest, and giving blood products and starting a master transfusion protocol. In terms of the physician side of things, relieving tamponade and using Perboa, basically the summary with all of that and their recommendations is like, if the system is not in place to, do it effectively and do it where you're going to be easily going to a hospital where they're going to have access to a surgeon, it's not really recommended. The next question that I wanted to address is, when to terminate resuscitative efforts? Like, when is it, at what point? Because, we have end markers for medical arrest. If someone has, a persistent low end tidal. There's no change in rhythm, despite going for say 20 minutes. There's something we have a lot more familiarity with medical arrests, but when it comes to trauma, um, there's not it's not as clear. Other than injuries incompatible with life, these patients do have good outcomes. As we kind of mentioned in the study, 70% of those that survived had survived at the 30-day mark, had good neurological outcomes. While it's still a low rate, still 1% of the total population, those who survive have good outcomes, a good neurological recovery. So looking at some of the guidelines of like when to terminate, ACS and looking at, just from ATLS, this was after 30 minutes, as you kind of talked about. ERC, the European Resuscitation Guideline Council, their biggest thing and the way they sort of recommended termination was after addressing all the reversible causes and, there's no cardiac activity on the point of care ultrasound if they're in like a PEA. If there's absolutely nothing, if there's like asystole, then don't even initiate. The NAEMSP and the ACS created a joint statement. It was actually originally in 2001, but it was as of right now, it's most updated in 2013, and it's currently their current guidelines. The national NAMSP stands for the National Association of EMS Physicians. ACS is the American College of Surgeons on trauma. The summaries that they sort of recommended for termination, because it can be difficult in the field, should be withheld. To not too surprising. Injuries incompatible with life. That's not surprising. In prolonged resuscitative efforts or prolonged cardiac arrest, there's signs of obvious rigor, signs of dependent lividity. For patients with blunt versus penetrating trauma, patients with a blunt source of traumatic arrest that were pulseless on EMS arrival, apneic, and had no organized cardiac activity on monitor, so that they were asystole, not necessarily PEA, but they had if they were PEA, that's considered an organized rhythm. But they had some sort of rhythm on the monitor. If they didn't, then they recommend terminating. And that also goes to the withholding of care. Like if they arrive on scene, if that's the case, one of the recommendations from the national standpoint is to not attempt resuscitation. In terms of penetrating trauma, again, these patients have a slightly higher return of spontaneous circulation. So it's a little more strict. It's a little more detailed. Pulseless, apneic, no other signs of life, and spontaneous movement, no pupillary response, and they had no organized electrical activity on the monitor. Then the current recommendation is terminating, not starting, and actually not starting with resuscitation. Overall, we looked at multiple interventions, which, were done in the pre-hospital setting. A lot of these things are not too out of the scope for, what we do on a daily basis for our ALS system. These are things that we are very consistent with what we know in the literature. Our blood products for traumatic cardiac arrest patients are going to increase outcomes. Decompressing the chest, relieving tension pneumo, looking for reversible causes. These are going to be things that are easily reversible in a population that is usually younger, has less medical comorbidities, as opposed to your 85-year-old who's a medical cardiac arrest. They tend to have much better outcomes after these things are addressed. There's a questionable role of epinephrine, which I would argue, I don't think was found to be not statistically significant in the study. I would argue that, the role of epinephrine and vasopressors, giving fluids, ideally blood products, but at least fluids of some sort, is much more important than trying to press an empty tank. Blood products in the field has been a discussion for a long time. Logistics and cost effectiveness, and also like, is there a benefit of the utilization? There's multiple programs in the country looking at that currently, especially that started recently. New Orleans is one program in particular. Um, some features again associated with low likelihood of survival, asystole as an initial rhythm, no signs of life, and no electrical activity on the monitor. They also, and this is across the board, emphasis of short on-scene time and rapid transport to a trauma center, just something that we already do. Any questions on anything? I think I went a little fast with that, but
No, that was actually pretty perfect. Some of the controversies and things that I wanted to address, unless someone from the peanut gallery would like to say something, I'm sure Matt will have some things to say to counter some of the things that I say. But I thought that the 20% Ross rate was actually rather high, but it kind of makes sense when you think about it. Like a lot of these patients go into cardiac arrest for a very specific reason. When you alleviate that reason, they get sustained Ross, right? So when you think about the standard things that we think about with just any kind of cardiac arrest, initial shockable rhythm, witness arrest, less than 20-minute downtime, bystander CPR, that kind of makes sense for this. One big thing is whether or not CPR is helpful in traumatic cardiac arrest. And that's one of the things that are controversial. And you kind of saw it on your stuff because when we looked at the different recommendations, um, ATLS says do CPR, while most of the other guidelines don't even mention CPR. They don't say don't do it, but they don't say do it at the same
yeah,
time. Because, again, like you said, pushing against an empty tank doesn't help. What is going to help? Filling that tank up, preferably whole blood. But besides that, next best thing is a little bit of blood component, and then the next best thing for that is, some people like to call it pasta water, right? Things along those lines. In a dramatic cardiac arrest, what is going to make a difference? If they have a large pericardial fusion, relieving that pericardial fusion. But how many people are able to relieve a pericardial fusion, right? Same thing, thoracotomy or clamshell thoracotomy. How many people are comfortable doing that in an emergent situation? Chest decompression. There's a growing body of literature that's saying that, yes, do decompression, but only when indicated. Other people say, and I don't know, some of you may know the name John Hines. He was Irish motor cyclist who actually he was a doctor who would follow the other motorcyclists, and then his thing was for major blunt trauma, intubate with a bougie, confirm with waveform capnography, perform a bilateral finger thoracostomy right away. Don't even listen for lung sounds. Place a pelvic compression device because all these guys are motorcycle blunt trauma, right? Strain any long bone fractures to length. Then they even talk about checking for a pulse because the idea is that you're trying to limit bleeding. You're trying to eliminate things that are going to slow you down. Administer a fluid bolus, blood if you have it, and then from there you can move on to start thinking about, hey, what's going on. Same thing like when you first learn ACLS. It's like, hey, call for help first. It's kind of making it that the things that you can immediately change and fix are already done. So now you can think about the H's and T's. Now you can think about the underlying cause because everything takes brain power. And then also you want to have a reliable system of what to do next. You know, so the biggest thing that you mentioned, and I would like to highlight again, and you highlighted it yourself, hemorrhage control is a huge thing. We learned in different military conflicts, such as the Persian Gulf, that reversible causes, such as a simple tourniquet, holding direct pressure, like you said, makes a huge difference. When I don't hemorrhage out 5 liters of blood, suddenly I survive. In the current literature and the current practice of giving whole blood, we've actually found that people who would have otherwise died, once you give them a couple units of whole blood, they're completely fine because you've stopped the problem and also you've stopped the loss. That you've done that hemorrhage control. Some people call that damage control resuscitation. Um, proactively stopping that hemorrhage. Delayed transport. In this case, they were bringing a lot of those resources to the scene, so there's no reason to transport. When you think about, you know, in some of these areas, they actually have tractor trailers with ORs in them, so they bring the OR to the patient. So you have a prolonged removal. So yes, it's a delayed transport, but you're doing everything on scene. Just like a regular medical cardiac arrest for us, we do most of the things on scene because we know that what else is going to happen in the hospital that we can't do. In this study, they're bringing those trauma resources to the field, so the you can't really compare the delayed transport to our system, right? We already found that epi doesn't work. We've known this. Epi helps to kind of get the heart going, but the heart's already going. Like use epi for what it is, as like a vasopressor, things like that. We already talked about IV fluids versus whole blood. We talked about John Hines. I made some notes while you were going. Um, you know, the Crash 2 trial with the TXA, not everyone believes in giving TXA in that first 3 hours, but this was through military conflict, but also through validation studies in the civilian population that if you start the TXA within the first 3 hours, it actually is beneficial. But you also have to continue that TXA infusion over the course of their stay. Because the thought is that you're stopping that clot early. I mean, you're creating that clot early, that sort of thing. Now, the problem is if you don't continue that, it's not for nothing, right? And that's sort of some of our problems, right? They also found that if you started it after 3 to 4 hours, it didn't help as much as if you started in the first 3 to 4 hours. And then, of course, Reboa essentially increasing that perfusion. And Reboa is a temporizing measure, but Reboa is only helpful in conjunction with whole blood, in conjunction with an operating room and a system of care to temporize that patient to get to that definitive care. And with that, that's all I had to say. Dr. Wong, if you have something, Dr. Steenberg, you guys are muted in the conference room.
Hey, Navin, can you hear us?
We can hear you now.
Yeah, so a few thoughts. I'm glad we brought up the ATLS, if for no other reason than to point out how old it is. 2018 is a long time ago in medicine. Unfortunately, it still carries a tremendous amount of weight, and there's been a lot of pressure for a long time on American College of Surgeons to update ATLS. There were people that felt that the ATLS guidelines were out of date in 2018 when they were published. So I agree very much that it's something you have to look at, but I very much disagree with the concept of using them as gospel. The European guidelines, the ERC, is another source of guidelines to look at. I guess relative to comparison with the rest of the literature, EMS literature, they're a little bit more up to date. And have some interesting things to say. So thank you again for going over those as well. Some thoughts, some good comments. You made a comment on survival time, greater than 20 minutes with blood. That there is data out there for transport times less than 20 minutes. And that's coming out of New Orleans and it shows benefit. And they have transport times in the 6 to 8 minute range in some cases. The other interesting thing about the New Orleans data is that it's not fancy when it comes to what blood product they're using. They're currently using PRBCs, old school red cells, and with the understanding that that's what they could get, so that's what they're using. They're not fighting the literature saying that there's better choices out there. They're just using what they can get. Tamponade, traumatic arrest, and presenting cardiac rhythm are another interesting thing that need to be considered. There's some fascinating data out of London HEMS, where they look at what they're doing from an intervention standpoint, based upon the presenting cardiac rhythm in a traumatic arrest. And there's some prognostication with that. They have hundreds of patients in a series that shows fundamentally what you talked about, which is that the patient that's in a rhythm other than a systole as a presenting rhythm has a much higher chance of survival. And arguably, that can be used as a prognosticator for efforts to attempt resuscitation and things like that. You talked a lot about futility and statements on futility and pronouncements in the field versus transport. And again, I think I'm glad you brought up the 2013 statement between NAMSP and the ACS. That is in the middle of being updated right now, and there's been a lot of work on that for the last 2 years. So I'm aware of some of those conversations. And there's a discussion about broadening that statement to be not just talking about termination, and to talk about traumatic arrest care in the field. And as a result, that may split into 2 separate statements. Nationally, there's a big conversation about that these need to be pronounced in the field because you're tying up a lot of EMS resources for futile patients. And then there's some pushback from the more urban organizations that are saying, nah, it's not a huge loss to us and we want to take the chance and bring them to the trauma center. And so people are struggling to figure out what the right language is, where there's an acknowledgement of the fact that a lot of these are futile and how do you draw that line? At the same time, if you have the ability to bring the patient to advanced care or to bring advanced care to the patient, that still has utility and being able to identify those patients. So termination of resuscitative efforts is very much a point of discussion at the moment. And there's not a specific number in terms of X number of minutes that you can use, unfortunately. I think clinical information, presenting rhythm and things like that shows promise. I agree with the emphasis on hemorrhage control, the de-emphasis of epi. Again, very, very helpful, very important. So those are my overall thoughts. Anybody else?
How do you convince someone to start a remote program with less than 1% of arrests actually surviving? Like,
So I
so many resources, you know what I'm saying? How do you get someone to convince someone to put a ton of money into something?
I wanted to bring that up.
So
There is actually, so I know a little bit more about the French system than what was presented here. No, but it's just the 3 of us. Do you want to come in here? Or you want-
Sure.
Yeah, I'm coming.
Well, it's still recording.
So, fine. All right, so there is actually a third tier to the French system, but it was only recently added. It was added in 2019 or so. It's been around before that and only did mobile ECMO. But the same folks that do mobile ECMO also do endovascular resuscitation, i.e. remote. And they also do blood products. So why do they bring that in? Because they think that it has value, and they wanted to offer it to the patients. The kicker with Rubella is the balloon uptime, and you have to be very, very cautious of the balloon uptime relative to where you're placing the balloon. We've known about this for a long time. There have been some interesting technological solutions to that problem, with doing like partial inflation or bringing it up and down or maybe tying it to computer control. but now it starts looking more and more like a balloon pump. But it's a similar concept. And fundamentally, what you're trying to do is extend the working time of the balloon being up and how long you can leave it for. In a zone 3 placement, so it's a placement trying to control bleeding in the pelvis, you actually do have a fairly long working time, generally speaking in the 90-minute range, before you get ischemia. And those are the patients that Reboa probably has the greatest potential to benefit. And they do exist. Those are the folks that get hit by trucks, run over by trucks, they have injuries to the pelvis. Depending upon where the bleed is, there may also be utility in some of the maternal hemorrhage is tough, but pelvic hemorrhage. And so the other piece of that is, again, a Reboa is a tool, but a tool that has to be used in a system. So as soon as that balloon goes up, the patient just got committed to surgery. And so you need to bring the patient to an OR where they're doing surgery immediately. There is no utility in stopping in the emergency department, having us do some stuff, et cetera. And so again, if you're going to deploy a Reboa tool, you have to get the patient to the operating room. You have to cut out all the middle people. Because you've now committed them directly and you're burning an organ on a second by second basis. In a zone 1 placement where you're placing it in the upper aorta, your working time is much shorter, 20 minutes, 30 minutes. And so really, Reboa has only been a useful tool being placed in a trauma bay as a recess maneuver to buy you a little bit more time to get the OR set up. In a zone 1 placement. There have been a few cases here and there of people using a zone 1 placement pre-hospitally, but again, the logistics have to be airtight. And you basically have to skid the patient right through to get them to some sort of hemorrhage control other than the Reboa, so that you don't get long-term damage.
Could you use this study as almost as you'll maybe put, like say you want to do Reboa in your system, like traumatic arrest would just be an exclusion criteria at that point?
So I think the conversation surrounding traumatic arrest needs to be separated from Reboa.
Yeah, I'm just saying, like, if you had to say
Yeah.
we were not gonna do it for.
I don't think Reboa is, so if you go back maybe 5 or even 10 years, everybody was talking about Reboa as being the answer for traumatic arrest. And I think what we've learned about Reboa, at least in the current generations of Reboa, is that it's probably not as able to be as universally applied as people were hoping that it could be.
Sure.
So it isn't the panacea that people want it to be. Does that mean it has no application? Probably not. It means it has a very limited application, and you really need to be very careful about your patient selection for who those are. And that is twofold. That's patient selection at the dispatch center for sending the resource that can do that. And then that's patient selection by the team that can do that, saying yes or no for the individual patient. And there have very much been successful deployments of Reboa catheters, but it's not the answer for traumatic cardiac arrest. The big answer for traumatic cardiac arrest is blood. It's the answer in the trauma bay when your patient starts to crumble, right? It's the first thing that people reach for. And it's increasingly becoming an available resource in the pre-hospital setting. And there have been some phenomenal saves using blood. Whole blood arguably is best. There's some anecdotal data that talks about improvement of the coagulation cascade and less units delivered and things like that. But any blood product being used is helpful. Do you use blood in traumatic arrest is a very interesting question. There's people that come down on both sides of that saying you're already in traumatic arrest. The numbers are crazy small. I don't want to waste this precious limited resource on the traumatic arrest where it probably has utility instead of utility. Then there's the other folks that say, well, if the guy's got any chance at all, it's with that. So why aren't we doing what we do? And so it gets back to that risk prognostication or trying to predict utility in the traumatic arrest. The thoracotomy stuff, there's finger thoracostomies, and there's full thoracotomy. Again, you really need to be targeting a specific problem. And that's where I think both assessment and patient selection become very important. I know Navin talked about John Hines and bluntly doing certain things in traumatic arrest. That's in a very specific patient population. You're talking about a motorcycle rider who is at a high rate of speed, usually like 200 kilometers an hour, flying off their motorcycle and hitting things. So you know exactly what the mechanism is, and you're choosing to tailor those things, because you know what your mechanism was right away. I don't think that that can be applied more broadly, although John Hines, I think, was revolutionary in the field relative to a lot of his discussions about resuscitation, and, blunt traumatic arrest and cardiac arrest, in the field. So I don't want to take anything away from him, but yeah, I think you have to put what he was doing in context in order for it to make more sense, and be careful that you don't just advocate for what he was doing to be broadly applied, without the appropriate setting.
I mean, I think the HEMS data, the London HEMS data kind of shows that, right? You can't broadly apply it.
Yeah.
There's certain people who will benefit from it.
Yes.
And these are the people that would.
So a lot of people react negatively to the London HEMS data because that you have a helicopter with physicians and a bunch of blood. And you're bringing all the options to the patient, not all necessarily, but a lot of options to the patient. Including in some cases, the physicians that are on that helicopter are trauma surgeons in the hospital. In some cases, they're EMS physicians. In both cases, they have very similar scope relative to what they can do when they're on the scene. I think that's a mistake. I think what you have to do is to say, look, you're bringing all the available options to the patient. And so let's take a look at what is being used and when and why. And it then provides some interesting places to test some hypotheses about, hey, if we were able to do these things earlier or later, is there any utility? And so, the London HEMS is not saying we're the best, we're the only ones, this is how everybody should do it.
But they don't have the data.
What they're doing is saying, we were doing our own quality assurance to make sure that we're doing as good a job as we can. And we wanted to share because we think there might be some things in here that, are useful. And honestly, one of the biggest things that I took out of some of that data, and if you haven't seen it, what I'm referring to is a presentation by, name escapes me at the moment, but it's the head trauma surgeon for London HEMS. It's available on YouTube, and it's specifically about resuscitative thoracotomy. The first half goes into the resuscitative thoracotomy. The second half goes into all this data. And what he talks about is using presenting cardiac rhythm, and there is utility for that in the sense of, let's get the cardiac monitor on the patient, even if those other providers aren't there yet, things like that. What rhythm are we in? Are we in a PEA? Are we in PFib, DF? Maybe because you're working with a traumatic cardiac arrest patient, PFib, DF, you fill the tank and you defibrillate, right? Which one do you do first? Well, if it was a medical arrest, I would defibrillate. If it's a traumatic arrest, maybe I work more on filling the tank and then I defibrillate. And that's, I can't show you any data that says that that's better, but I'm saying we think that we understand that without blood being pumped around, there's not a lot of utility in fixing the cardiac problem. So, maybe our sequence needs to be a little bit different in traumatic arrest.
Yeah, I mean, I think if there's kind of one thing to take away from this study, at least, it's interesting to see that, a lot of what we traditionally know about pre-hospital trauma care might not be true, right? Like we're in that area of ambiguity right now where we're learning new things and applying new things and figuring out better ways.
Sure. So, I think a great example of that is airway, right? And we've always emphasized airway, and airway is still emphasized in trauma bays and things like that. I think there's emerging data to show that maybe airway isn't where the emphasis should be in traumatic or in severe trauma, patients that are on the edge, patients that have arrested. Not to say that airway isn't important at all, but that it's not necessarily the first thing that needs to be fixed or the preeminent problem. And so, given that there's a big emphasis on airway for many other things and many other EMS problems, and we have providers that can intubate caring for the patient, they have a tendency to focus on the airway, when maybe in the trauma, they should focus on the other things and worry less about the airway it depends, and again, you have to respond to the clinical situation. If the patient's severely hypoxic, then perhaps we need to fix that airway. If the patient's not severely hypoxic and we're just doing it because we think that's the most important thing to be doing, maybe it isn't. Maybe that's, fixing the bleeding in some other way, doing some hemorrhage control, or more of an emphasis on transport. So, the trauma surgeons are the ones that are kind of yelling at some of the EMS agencies about that, and it's been a little bit,
Uncomfortable?
uncomfortable or contentious. But I do think that there is some signal in what they're saying, and that we would be remiss if we didn't acknowledge that. So it's not just trauma surgeons being trauma surgeons, I think they're queuing into a point that we need to make sure that we understand. So, and again, that's probably the better way to collaborate. So.
Yeah, the last thing that I would leave off with is there's also the thought of permissive hypotension. So you're giving them enough fluid so that you're maintaining a blood pressure. It's not going to be 120 over, 60, but it's, something. So you can't have it be too low that you're not perfusing, but preferably you're doing whole blood and things like that. So.
The caveat, of course, to permissive hypotension that I think we'd be remiss to not mention, or not, if we didn't mention, is that if the patient's a polytrauma patient with a head injury, permissive hypotension arguably goes out the window.
Yeah.
And that's because of the EPIC TBI data. If you're not familiar, again, look at EPIC TBI studies. It's out of the University of Arizona. There's probably 15 or 20 papers. Dan Spade is the main author on most of them. And but again, it's pretty clear that hypotension in the setting of a head injury is a predictor of worse outcome. So that's the one place, unfortunately, where we can't tolerate the permissive hypertension in the same way. And you may have to more delicately balance this concept of popping the clot versus knowing that you're not perfusing the brain. So. All right.